All right. Okay, let's get started. So, hi everyone. Thank you very much for being here today for our CST Pediatric Group educational webinar. I'm Camille. I'm a pediatric nephrologist at Saint Justin Hospital in Montreal. I'm very pleased to introduce my dearest colleague, Caroline. But just before that, I wanted to share with you a couple of Zoom skills you're probably good at after almost 6 years after the beginning of the pandemic. But please keep yourself muted until the end of the session when we will have time for questions. If you have any questions during the presentation, please write them in the chat box and we'll take time to answer them at the end of the session. And if you can, please turn on your camera. It's always a little bit more nice for the presenter to see some faces reacting. So, Dr. Caroline Lemoine is a transplant surgeon at the Saint Justin Hospital. She's also specialized in hepatobiliary surgery. She completed her fellowship in Pediatric General surgery at Saint Justin, Montreal in 2014, and further pursued training at Northwestern University in Chicago, where she completed 2 additional fellowships, the first one in pediatric hepatobiliary and transplant surgery, and the second in adult and liver kidney transplantations. She practiced for 6 years at Lurie Children's Hospital of Chicago and further joined the Saint Justin team in September 2023. While Dr. Lemoine's practice includes general pediatric surgery and transplantations, she specializes in the surgical management of disorders of the pancreas, bile ducts, and liver, including congenital vascular anomalies and portal hypertension. In parallel to her clinical activities, she is also highly concerned by the environmental crisis, and she is interested in minimizing the impact of the healthcare system on this global problematic. She's an active member of the Saint Justin ECO CMDP, Council of Physician, Dentists, and Pharmacists, where she strives to implement sustainable practices, especially in the operating room. So without further wait, thank you very much, Caroline, for taking your time and energy to present us about this very important topic.
Yeah, so thank you very much, Camille, and thank you to the CST for the pediatric subgroup to invite me to present today. So as I was telling Rob and Camille just before joining on, I said, oh, I'll be happy to talk about the environmental impact of pediatric transplantation. And so you will see where that goes. So I have nothing to disclose, no disclosures, besides the fact that I'm very interested in the climate crisis, how the healthcare system impacts it, and what measures we can take as physicians, nurses, and other practitioners of our system. Here are some very elegant objectives that were created to look at how what contributors of the pediatric transplant programs may impact the environmental footprint, see what strategies we can use to reduce waste, energy use, emissions, without obviously compromising patient safety nor quality care, and see how we can change things from a institutional standpoint. Again, very nice objectives on paper. You'll see that some are maybe easier to answer than others, and you'll understand why shortly. So, general things, nothing groundbreaking here, things that everybody knows, but from the UN website. So a few years, about 10 years ago, there was the Paris Climate Change Conference where a number of countries came together and said, we need to do things differently, right? Because the temperature is rising because of climate change, and soon it's going to be plus 2 degrees Celsius. We need to limit this. However, since 2019, so only 6 years ago, we're already plus 1 degree. And actually, if things keep the things keep going the way they are, by 2100, we're going to be plus 3 degrees. So that's even over what we're trying not to reach. So what is the impact? This is one of the saddest pictures ever, right? The polar bear on its floating ice cap. Nature, diversity, like awful things are happening all across the world. Maybe closer to us as humans, food and water insecurity, right? Soil degradation. Um, Millions of people live in areas affected by erosion, and this is affecting obviously drinking water and agriculture. Weather extremes, right? It used to be that those big fires, big floods, we kind of heard about anecdotally, but here they are. They're becoming more frequent, and all continents are now touched by those climate-related events. And importantly, conflict, right? Because there's heightened competition for resources such as land, food, and water. Um, and because of those conflicts, there's mass displacement of populations. And this is creating other issues elsewhere around the globe. Um, the planet is struggling actively. So I like to think to myself, like, what can I do as an individual, right? And you probably all know these, what climate change actions you can do at home. So, and I don't like to pride myself, but I'm a very like green oriented person. So I try to do these, like, what can I do for energy saving? I have semi recently switched to active transportation. I walk, I take public transportation. I try to reduce my meat consumption. Be mindful, like how often do you travel? Take a plane. Like try to really use the food that you buy, right? Don't throw it away. The very ever famous reuse, repair, recycle. I have a hybrid, not as good as an electric, but still making a little change. What I have not been able to do is change my home's source of energy. Uh, but this might be something to look into the future. So those are things that I think most people, especially in Canada, think about, are conscious about, and try to focus on. But realistically, as a pediatric transplant surgeon, sometimes I spend more time at work than I spend in my own house. So actually, what about the climate actions on my workplace? So this is the Rue Saint-Justin with the new and the old building. And the institution has done some pretty cool work in the cafeteria. So there used to be that the satisfaction level was pretty low. People did not like the food. So they switched things around and now it's a room service kind of concept. So they have reduced waste by 45%, and the satisfaction of patients has gone up from 50 to almost 100%. And they are, um, the money they're saving is almost 100,000 K. So it's big. And obviously the ever famous, how you manage waste. So we recycle, there's compost, where you throw waste. And there's also a really nice initiative by our pharmacy where they are the first green pharmacy in the province of Quebec, where they have really reduced their carbon footprint, and they are really leaders in this. So this is very nice. And the pharmacist that's the most involved is also the co-president of our Eco CMDP, so our Eco Environmental Council of Physicians, Dentists, and Pharmacists. And actually, since 2019, every institution in the province of Quebec hospital has to have sustainable procedure and oriented on how we can improve it in each institution. So England, in parallel, is reaching a neutral carbon footprint of its entire healthcare system by 2040. Okay, we're clearly not there yet, but just to say that some people are really thinking about it, and that motivates me also. So I started looking at close to home, so pediatric surgery. I actually saw that paper while I was just coming back to Montreal, where the Lurie team had done this pilot study of feasibility of recycling in the operating room. And I was like, wow, we've been doing recycling in the OR at St. Justin since 2010. And in the United States, they're at the point of doing a feasibility study. Is it going to cost more money? Is it going to be more time consuming for the nurses? And I was like, wow, I mean, we're maybe a little ahead of our game. So I thought, but we're not alone, right? So orthopedics, urology, anesthesia, and intensive care. So various medical surgical teams are wondering, what can we do? How can we be better? How can we improve our impact? Because we strive to take great care of our patients, but especially in the pediatric world, you try to improve things so that you give them a better future from a medical surgical standpoint. But then, but what if there's no planet for them to be on, right? What if what we leave them as future generations is actually dismal of what we had in our days? So we have to think about these things. So getting to transplant, right? Well, so here's the kicker. There's not a whole lot about sustainability and transplant. So here goes my environmental impact of pediatric transplant presentation, but we'll still get to something. Go kidneys. So as not often, but there's a big nephrology community, right? And most of the publications in sustainability, I'm not going to say directly to transplant, but certainly circa transplant, meaning kidney care, pre-transplant, chronic kidney disease. There's some data out there. Um, Liver, one paper. Yay, we did it. Um, Heart, bowel, lung, pancreas. Unfortunately, nothing. And pediatrics, nothing either. So for whoever is interested on this Zoom meeting, this is a world to explore, and we can really pave the way. We can in our own institutions do things. We can regroup. We can think about this, and I think the pediatric community should really be leading this effort because of how invested we are for our pediatric patients over a long course of time. So I've decided to talk a bit about what actions can be done before transplant, at the time of transplant, and after transplant based on what I found, which is a lot of kidney papers, one or two liver papers, and we'll see where it goes. So from a transplant standpoint, like I said, go kidney. It's been really well described. Like chronic kidney disease, I mean, it is a burden clinically for patients, but it's really bad also for the environment. So the average greenhouse gas emissions per person is almost four times, more than four times what it is for someone who's not on dialysis versus a chronic kidney patient that's now on dialysis. And you can also see that the greenhouse gas emissions increase as the severity of disease increase. So there's a CKD stage 2 versus CKD stage 3, plus the impact of gender on the tons of CO2 equivalents that are produced. And this is a non-exhaustive list of where the burden comes from. And I think it's pretty self-explanatory to think about dialysis as a very, very big measure or somewhere we can act upon to improve the carbon footprint impact. So water consumption, reverse osmosis, this water is wasted afterwards. The medicines, but imagine transport. A hemodialysis patient comes, takes car generally versus public transportation to come 3 to 4 times, even more sometimes in pediatric transplant, in the pediatric world, to the dialysis unit. So, and then energy, right? All the machines, dialyzers, like everything. Also, it can't be too hot in the dialysis unit. So you have to, adjust the heating, adjust the lighting, there's just so many ways on how dialysis impacts the environment. And that's really where the bulk of the literature stands actually in the kidney world. Oh, sorry, there was this guy here. So looking at the greenhouse gas emissions across the life cycle of chronic kidney care, and you can see on top here is everything that's pre-transplant. So dialysis, this is transplant here, and this is medication. They've just put it separately. But really the drivers of environmental impact in chronic kidney disease is dialysis. And within that, there's hospitalization. So a patient being in-house, what it costs, the resources that are put, and resources mean what is used and what is thrown away, and definitely transportation, again, associated with dialysis. So you can see that in comparison, the numbers are pretty big for transplant, but as we'll see later, transplant is really big upfront. So a transplant hospital stay, including the procedure, including the procurement, is a big footprint. But then in the long run, if you compare it to someone who can be, especially adult patients, who can be like 10 plus years on dialysis, this really accumulates over time. So in the kidney world, and I'm going to preach to the choir here, like if we transplant more, or if we could, then definitely if we could take more people off dialysis, it would be really beneficial to decrease the impact of chronic kidney disease. So that's a big thing. But then I can also say that yes, they say that we should push for a preemptive transplant. But at the same time, you transplant someone too early, they get some bad virus, they get PTLD, and then you're like, well, here goes my environmental impact. I had something else in return. But obviously, you weigh whenever your patient really needs transplant, but something to think about. So getting back to dialysis, so water, energy, consumable. That's really the bulk of the problem. And if you look at how much, like in the United States, like how much power is used through hemodialysis facilities, how many houses that corresponds to, that's just so many households being lit 24/7 for a year just because of how much it's used. And if you look across modalities, hemodialysis is a lot more costly from a environmental standpoint. So you can see like electricity, machines, how much patients need to travel, consumables. So PD is superior to hemodialysis from an environmental standpoint, but obviously PD does not fit every patient. And even the cycler is less environmental friendly than the CAPD, so the automated one, the continuous automated one. So again, does not apply necessarily to all patients, but something to think about. That's just another way to look at it, but just how much fluid and travel is involved with hemo as opposed to PD. And that's not the sole reason why we really encourage patients in the pediatric population to go on PD, but definitely that's maybe one additional argument when at all possible. From Europe, they were looking at how much water it uses, like it's millions of meters cubic meters per year. PD again, lighter impact. But nevertheless, even on PD, you have to get those bags, you have to produce those bags, you have to transport those bags. So there's still an impact. This is a comparison of automated versus continuous ambulatory I was talking about. And maybe recycling plastics more because there's just so much plastics, right? In dialysis. Again, less, but still. So I don't want to go through everything that's been said and done on how a dialysis facility or a kidney program can improve the environmental impact of dialysis, but I think Australia and New Zealand they've really been trailblazers. There's a lot of stuff coming out of there. They have a nice guide to design and operate facilities. And in Europe, there's the KIT New Care approach, which I thought was pretty cool. So it's a European funded project, and it really looks at reducing the environmental, social, financial impact of dialysis. Obviously, always improving sustainability and not decreasing quality of care. So it's a group that includes, oops, sorry about that, transplant nurses, kidney nurses, kidney teams. So it's very elegant. It's like a big European Kidney Health Alliance. So they really looked at energy, water, transportation, the plastic waste, and just concluded that as the way dialysis is going right now, it can't keep up. It just cannot, if you think about how much waste it creates. And so those are just like other places you can go pick up some measures, but just to a quick, this one, the European Dialysis and Transplant Nurses Association and European Renal Care Association. So that's the EDTNA, ERCA, what it stands for. And if you go on their website, they have an environmental checklist. And it takes you to this website. And you can actually, in real time, evaluate how your dialysis unit program stands. Like, where are you at? What's your score? Like, where do you stand? And what are the areas you could improve? So I thought that was pretty elegant, pretty cool. As a place to start, at least start a conversation maybe in your institutions and maybe identify low-hanging fruits of maybe going to administration or depending on what the healthcare system, obviously in Canada, it is what it is. But nevertheless, maybe you can go and advocate on places to start. And they also have this, which is the Green Excellence in Dialysis recommendations. And they really have created nice categories of recommendations. So for example, general considerations, awareness in patients and staff. So encourage staff to use green modes of transportation. I don't know how possible it would be doable or not, but if there could be an incentive for practitioners at institutions to take bus or train or just don't take their car every day. If you have, that does not apply to us, but maybe some of your programs like renal units that have vehicles, make sure they're electric or they're hybrid. Monitoring, measuring, and analyzing. So if you want to know how you can improve, you have to measure things. So what's your monthly water consumption? What's your monthly electricity consumption? How much hazardous waste do you generate in a month? And then going from there, you can see, again, what areas can be improved. Good green clinical practice. So I'm going to say stuff that I don't really work with. So nephrologists, please don't throw anything at me. But they were saying consider prescription of lower dialysate fluid rates, increase blood flow rates rather than the dialysate flow rates. Maybe this means something to you. And then if you go into the good non-clinical green practice, so the waste management, so it's kind of silly, right? But maybe you don't have one garbage can. Maybe you really separate your plastic, your paper, your actual waste, so that the recycling goes where it needs to go. If you can, maybe avoid certain types of plastics that are not reusable. And that's not easy, right? Because we don't individually order what we want, right? It's like provincial. But nevertheless, I think if many units put themselves together, then maybe you have more impact. Technology that reject water. When we said the reverse osmosis water, maybe it doesn't need to be thrown away. Maybe you can reuse it for toilets. Maybe you can reuse it for the grass, or like there might be other uses or you can do closed circuits and use it for ventilation. So there might be ways to reuse that water and not just throw it away. And lastly, facility management, maybe a little less easy for us, but if you design where they stand, maybe you avoid a room with direct sunlight because you'll have to use more cooling systems to keep your machines and to keep your patients comfortable. Anyways, and I like this one, support the transition from paper-based medical records to EMR. Yes, we would really love that in Quebec. We hope it's coming soon. For those who have it, this is a green initiative. And again, so that was maybe a more HD in-house setting for dialysis, just a few things that they were talking about. So I think the plastic recycling program is a big one. And interestingly, in Mexico City, they had a PD center that recycled the PVC, the plastic. And for 12 patients on automated PD for 1 month, that was 120 kilos of plastic. So it's small things, but if you start somewhere, then we can make changes. A little shout out to Canadians, as we are. 2 years ago, a very nice across the country from coast to coast survey of kidney care professionals with a lot of nephrologists, and shout out to the 14 pediatric nephrologists who answered, 4% of the entire cohort. Most people are from Quebec, BC, and Alberta, but nevertheless, um, a few things that I read on this one too. Yeah. So a few just responses. It was really focused on what you know, like knowledge about climate change, your attitude towards it, and your practice. So 92% were informed about climate change, at least to an average degree. Interestingly, women felt less informed, and older people greater than 60 years old and younger people less than 30 felt more informed too. 71% were extremely concerned about climate change, and 39% were really concerned about how much water waste, how much waste is generated by their own kidney program. And many people deemed that it was very important to reduce the footprint, but concretely, about 14% frequently took steps to reduce their own carbon footprint in their personal life. But almost like 40% were really interested in having more sessions through the Canadian Society of Nephrology to have uh, insight about sustainability initiatives in kidney care. So we want to do something. Now, what are we going to do, right? So another survey by the same team, actually it was the same survey, but they had the sub-analysis of the environmentally sustainable practices, including 421 kidney care providers, about what are the strategies in your actual workplace. And not surprisingly, anything that had to do with the institution, like power consumption, lighting, electricity. Well, okay, so physicians and nurses don't really know much about this, but they were really concerned about how transportation, consumables, office equipment, and recycling could have an impact. But sometimes when you compare yourself, you're like, how can we strive to be better? And we compare pretty well to Japan, like 18, 19% facilities have policies or have green teams, but Australia is almost double that. So I think as members of the Commonwealth, we can strive to get like our Australian colleagues and do more. Okay, so that was like the kidney stuff. And now for the liver stuff, I have like 3 slides. So it's not going to be the same. And I really didn't find a whole lot on liver. This was a paper by the Italian people, the Society of Endoscopy. Okay. And they said, well, if you do scopes, you're going to generate a lot of waste, right? Because it's a lot of consumables, non-reusable beside the scope itself, a lot of plastic. And if you have a high volume center, it's like 500 kilograms for 5-day work. Low volume, it's less, obviously. But if you look at in the United States, the amount of scopes that are done, it's like 18 million. It's 117 soccer fields with 1 meter high of trash. And that's a lot also the PPEs because they're non-reusable. So they had looked at measures like how we can improve, but unfortunately, those don't super apply to children in the pre-liver transplant setup, like avoid EGDs in young subjects less than 45 years old. Okay. Avoid screening colonoscopies in low-risk subjects. So this is really for the adult population. But maybe the one I liked was avoid EGDs for variceal screening and surveillance patients with cirrhosis with a very low risk of varices. I think the number of pediatric patients pre-liver transplants with portal hypertension, I mean, it's not a very big contributor, but I think this might be the one place we could think about it. They were also trying to think about like non-invasive tests in lieu of endoscopic examinations. But again, there was one paper I was really excited, but not super applicable. So pre-transplant, a lot of work can be done in all organs. I think kidneys, you're leading the way on what we can do and how you can improve the dialysis side of things. And the other ones we just need to keep up. with you guys. So I think coming to me as a surgeon, I was really thinking about the impact of procurement when it gets closer to transplant. And there's surprisingly not a lot of data on that either. So two things that came from the United States. So for those who might know, but in the States, they changed the allocation system to acuity circles. So based on your transplant program and where you are located, but they've become bigger so that the distance travels for organ recovery has increased. And you can see here by Oregon, and you can see the CO2 emissions are pretty big, especially for lung and heart. Kidney, it's a little less, but as we all know, there's more kidney recovery centers. There's more surgeons also comfortable in harvesting kidneys. But nevertheless, the overall CO2 emissions attributable to the excess distance traveled was 14 million kilograms of CO2. That's a lot of CO2. So what is it compared to? It's like almost 7,000 gasoline vehicles driving nonstop for a year. It's 3 million gallons of gasoline being used. It's 6,000 houses that you just leave the lights on for a full year. That's a lot. And for what is the worst and what is the best? So kidney is like, again, like, yay, maybe winning a little in the sense that kidneys, especially if they have to go across countries or from coast to coast, sometimes they're put on commercial flights. And the carbon footprint of those is less than one of a charter flight because there's just more people flying on it. But if you can, ground transportation is better. But obviously, especially in Canada, it is what it is. If you really have to go get a liver in Vancouver, then you just got to go, or to Newfoundland. So there are limitations to us, but there are ways to think about this. The only other paper I found was about liver. This is from Texas. And they looked at a year of liver procurement. That was 160 60 or 63 procurements. And they extrapolated it to the number of cars, again, driven for a year, the number of the acres of forest that would be needed to sequester that amount of carbon over a year. So for their study period, you would need like 1,000 acres of forest. But this is only them. So if you look at the number of flights that were needed, that's like 55,000 acres of forest that need to sequester that carbon. So that's a lot. That's a lot. So what can you do? Well, drive rather than fly. I think we don't have that same problem here, at least not in Quebec, but like in Texas, they would take a flight for something that's 2 hours away. And I think if you have like a patient in dire need, it's one thing, but maybe sometimes you can just take a car. An idea that we had in Quebec that hasn't unfortunately really panned out is donor facilities. Like move your donors closer to your transplant centers so that you reduce, you don't have to travel as far. Local recovery surgeons, when at all possible. So you fly to Oregon, but you don't have to fly the team. So that's only one way, not two ways. Those were the big things. So a lot of work to do when it comes to procurement. I think the pump helps also because this way you can make more distance for organs, but it's an imperfect setup for sure. I'll talk a little bit about the OR because this is stuff that actually projects we have worked on here, obviously because it's a little closer to me. But if you look like overall healthcare is 10% of the greenhouse gas emissions, the OR is 1/4 of the entire waste produced in hospitals, and a lot of it is plastics, and most of it is recyclable, if only we recycled it. So in pediatric surgery, there was a survey similarly to the one by the kidney team. We think it's important. Very few are involved. Like there's just not that kind of initiatives in our institutions. We think it's important to recycle. It does not add any cost. And we've been doing it for 2010. So I was really excited, but it's better not to buy stuff or use stuff. And then if you have to, you recycle it, but it's not the best solution. One thing that we created after doing a big lit review is some sort of a feasibility score that you guys can apply in your institution, like measures based on human, financial, material, and organizational resources. And we've given it like a score. And obviously, if you only the pediatric surgeons have to do something, it's not as complicated if you have to go to the government. If it costs nothing, it's easier than if it costs a ton. And if you can do it fast rather than on the long term, again, gives you more point. So we found those initiatives here and we kind of classified them. So the surgeon preference card is what we use in the OR. So that's pretty low hanging fruit. Trying to better organize our waste management, make sure our trays, surgical trays, are up to date, try to reduce how much we use in the OR, work on how our sterilization team works. And lastly, that's going to be my baby over my career, reusable surgical gowns. Like I don't want to throw gowns and drapes anymore. But obviously, my dream is the more complicated one because it's going to cost a ton of money. But Ottawa is working on it. So, I mean, there's some places that are starting. But again, that's just that little triangle I talked about earlier. So we did that for our transplant here at St. Justin. So the three pediatric liver transplant surgeons, and we're three transplant surgeons plus a urologist, now two, but one that has a preference card. We optimized our card. So looked at what's on it and what we actually want opened all the time versus what we can open as needed. And we decreased the amount of items significantly. We decreased the cost significantly, both for liver and for kidney. I had done the math of how much it costs. I think the Americans would be like, I can't believe you're doing transplants with that amount of stuff because there was so much stuff opened in the States. But I think that's somewhere that transplant programs can start for the OR part and really have an impact. And I had looked at two pediatric liver transplants. And you can see that a lot of what's created, there's waste, sure, recyclable, a lot of biohazard, but it's not actually real biohazard. It's just that those big yellow bins are so big that a lot of stuff gets thrown in it that should not be in there. It's just easier. So we're still recycling. So we do recycling on all cases, big and small, but it could be optimized by a fourth, and we could really increase our amount of CO2 savings. And again, nice little comparisons just because it's more visual. But if we really did, if we extrapolated it to the amount of pediatric transplant in a year, liver and kidney, that's a lot of gasoline, a lot of trees grown when we're talking about those acres of land to sequester carbon. So, yeah. Going into post-transplant, and that's the last part of the presentation. So I'm going to go through this. But so I mean, obviously you care because you're here, but why should we care? And I think especially for transplant recipients who are more prone to infection because they're immunocompromised, climate change and infectious disease equals badness. Disease appears in places that it shouldn't. You have more heat waves, you have more dehydration, high kidney. And then how do you get your people to come to your institution if it's so hot outside that they can't take, if they don't have a car, they're going to take the bus and then it's going to be complicated. And then what about those climate events? Like who across Canada has a disaster plan for transplant recipients? If there's another ice storm and they just can't come to dialysis and they just can't come to transplant clinic, like what are we going to do? So that's the quick thing I said earlier for the impact of kidney transplant. We could transplant, it's better than dialysis. And those were the impact. Upfront, it's more. Down the road, it's less than keeping someone on dialysis. That's just another way to see it. So dialysis is up here, transplant is down there. And obviously, if you can do a living donor, then generally your living donor centers are close to home or close to your home institution. So you have less transport, and therefore you don't have the burden, the environmental cost of procurement transportation on you for that transplant. They were saying also, and I say that very humbly because I don't do a lot of the post-transplant follow-up as opposed to hepatologists, nephrologists, cardiologists, and other medical providers. But in the UK, they had, that's adult, they had created a virtual clinic follow-up clinic for 68 stable patients. They did not really specify what stable meant, but presumably like no PTLD, no virus, nice creatinines. And they avoided 43,000 miles of travel, which was 12,000 CO2 emissions averted. So I like to see my patients, but at the same time, maybe that's an alternative to consider to decrease the impact of environmental pediatric transplant. For livers, one paper in Italy, them again, that's adult, but they looked at how much, what's the carbon footprint of an adult transplant. And again, it's a lot of power, anesthetics, the waste in my recycling program, not as much when you think about it, and blood transfusions was actually a lot. And that was for pretty stable patients. I mean, mean MELD score of 13 out of a scale that goes from 3 to 4 to 40. And again, that's just another way to put it. Like the longer the surgery, then you have more resources utilized if you use the pump also. And that was a list that they were suggesting of like places where we can improve. And here's my drapes, gowns, and gloves. One day, I dream about it. We'll have reusable gowns again. So that was just again their footprint, and that it was the equivalent of 800 miles driven by a single passenger vehicle. So that's a lot of gasoline and car utilization for liver transplant. So we're at the end. So there's really not a whole lot of literature on the environmental impact of transplant. So heart, lung, thus liver, pancreas, and bowel. Let's try to ramp up our knowledge, like the kidney team is doing. And it's different, but still, I think we can do it. I think we need to add to the body of literature to really know what's going on and how we can make changes. I think we know, but I think we must recognize what impact we have, but also like we all want to give a better future to our transplant kids, but we also have to leave them something to live on. So we have to take action. And just a few things. So in your own institutions, you might have those environmental council of physicians, dentists, pharmacists. Be part of them and see what you can do. You'll have conversations with administrators, with the government. You can be a part of the Canadian Association of Physicians for the Environment. In Quebec, it's the AQME. They also have ideas on how you can start in your own institutions, and phone a friend. If you know of someone that has started initiatives in their own institution, just call them and be like, where did you start? What did you do? And how can I do that in my own place? And if we just all get on the train, it'll work. Maybe I should say the subway. It's more environmental friendly. But I think we just all have to think about it as it's not adding to the bulk of our work. It's just part of our work. We kind of just have to do it now. So I'm very motivated by the environment. I hope you all are too now. And I'm always happy to talk about this. And if anyone wants to work on national initiatives or collaborations on projects, I'm always happy and looking for friends. Thank you.
Thank you, Caroline. Thank you so much. I think it just made me realize we need to add environmental impact with the factors we put in the balance for some of our patients' decision, which I was not trained like this during med school and residency, but I think it has to be one of the factors to be taken into consideration. So I don't know if someone wanted to ask any question. There's something in the chat. Chiaoi, always thought kidneys were cool. Yeah, agree.
Yeah, hello everyone. Can you hear me?
Yes.
Hi, my name is Sabah Salim, and first of all, I would like to thank you and really acknowledge the great presentation that just has been delivered by Dr. Caroline. This is indeed a timely and like a much needed area of research. I was just looking into the like literature and all the papers she cited, and I agree that there is um like a lot of scarcity, especially when it comes to the kidney transplant. Environmental impacts. I just want to add here that we have recently published a paper in which we did like a detailed comparative analysis between all the KRTs, including kidney transplant. And this was like kind of first study which discussed the environmental impacts of kidney transplantation on like a detailed level. And we not only like calculated the climate change impact, but also impact on the different environmental impact categories, as well as the hotspots of those emissions, like how can we reduce those emissions. And as she was like describing the different um, like solutions, how can we reduce the environmental impacts coming from um, uh, the transplant, and then coming from the like organ travel or patient travel. So these kind of details. And I'm an engineer, I'm not a doctor, but I'm working on this project. And I have got this opportunity to work with some amazing transplant surgeons and then nephrologists. So I'm just like trying to understand like how these how best we can do in this area. And especially it was very like interesting to for me to hear about the pediatric transplant. And I am like curious to see how these impacts could be different than adult kidney transplant, or then the deceased or living kidney donor transplant. So I was just wondering that is there like any other way or any projects that you're working on which you are looking to look into the like evaluate the impacts of this pediatric kidney transplant, or any specific methodology, or like how you plan to like dig more deeper into this? Thank you.
Yeah, thank you. And I saw your paper. I was running out of time. I almost ran out of time anyways. But you are absolutely true. You had a very nice paper on that subject. And again, there was a survey out of Canada, but there was definitely your comparison also of modalities. So the two projects I presented a little more are the ones that I'm currently working on. So one is really waste management in the operating room. We shouldn't just recycle. We need to reduce at the source how much we buy. So we have to talk also about consumables. But that's why we worked on the surgeon's preference cards. Because if we actually point out the items that we really want, then maybe some things we don't have to buy as much of. So we'll reduce cost, but we'll also reduce what is used and not what we open and not we don't use in a transplant and is just thrown away. And then what is thrown away, where it goes. At the same time, there's an anesthesiologist, Dr. DeKoven, that works on the anesthesia side for the anesthetic gas utilization, because that's a really big contributor in ORs as far as the environmental impact, carbon footprint. The big project down the road is those reusable gowns. That would be my big dream. We had an in-between project about recycling more stuff in the OR, like recycling gloves, recycling masks has started in the hospital, recycling gowns, disposable gowns, disposable drapes. But this gets a little more complicated and convoluted because it involves waste management in the institution, and I'm not in charge of waste management. And obviously, it costs a different amount of money to just send stuff through the city of Montreal to the waste field rather than through another company that processes them. That's going to cost something. And to convince administrators currently in the Quebec healthcare system to pay money to gain on the environmental side down the road. But right now, there's not enough money to build a hospital or renovate a hospital that's falling apart. So I think it's difficult for the government and the administrators to really see how important it is to work on the environmental projects, as they need to put down fires elsewhere. So there's a lot of initiatives in the institution in other projects like the intensive care unit or the pharmacy, like I said. But as far as transplant is concerned, like I'm working more on the surgical aspects, but now Camille is super pumped. So we can work on the dialysis unit. But yeah, I'd be super happy to work on this, or even the liver teams. All the scopes that are done, I think, is another nice place to start. And I think the big difficulty in Canada is the distances for patients that they have to travel to come to us. And I don't have a good workaround for that. Besides, if there's a good public transportation system, then maybe they are willing to park outside the city, take the REM, which is like an overground subway, to get to the hospital. But it has to be user friendly, right? And I think right now public transportation in Quebec, at least, is not comparable to, for example, what it is in Europe. So it's difficult to convince patients that are coming from afar.
Okay, thank you very much.
Shall I?
Yeah, thanks, Cami, and thanks, Caroline, for this really nice talk. I was just gonna maybe give a bit of a shout out to like Katie. I don't think she's here, but on the note about distance travel to like clinic visits and stuff, I believe we've seen some work that she and the BC group are working on with regards to the environmental impact on like clinic visits and stuff in the transplant clinic. So maybe it's something that, you and her can continue to have the conversation too.
I was thinking the same
Absolutely.
thing as you were presenting, Carolyn, because we do a lot of work on environmental impact in virtual visits and sort of the CO2 emissions from our multi-organ transplant program. And so, one of the things that we've thought about is in terms of managing emissions is can you do like an outreach program? Because our cardiology program has outreach, and could you
Yeah.
create something similar for the multi-organ transplant program?
I think that's a really good point. I'm not exactly sure how the situation is where you are, but I'm looking at Camille again because she's there, and Fernando's on the line. But it feels like the practitioners right now in pediatric transplant in Quebec are so stretched in all directions that to add to their work and say, you're going to go to an outreach clinic in Saint-Jérôme or in Sherbrooke, or I mean, there's other providers anyways in Sherbrooke and Quebec City, but I mean, for let's say the Saint-Justine program, like I don't know that that currently they have the manpower to do it. So there's a question of also the providers and your team or nurses or APNs that you can send. So it's multi-level, but if you can, I think that's a great way to reduce the footprint.
And as like just having more collaborators, let's say for us, like up north in Quebec, we have some transplant patients who we have agreement with their local pediatricians, and we do like telemedicine with them, and they make sure they have no adenopathies, and we check on the EBV PCR. So sometimes just having like hands and eyes on your patients who live very remotely, and I know it's a big deal in Vancouver as well. I think it's pretty helpful, and pediatricians are usually super happy to help.
No doubt.
Any other questions? Okay, maybe I have one last. What do you think is next? Is there any like biodegradable plastics to be used instead of like recyclable, or do you think we're gonna get to a point where we're gonna be able to recycle biohazard? I just think of like all the filters and the tubes and hemodialysis for each patient, and every time I'm in the room seeing the nurses get like patients off chemo and the big like trash bin yellow of biohazard full of plastic and blood. But do you think that we can hope that at some point we'll be able to recycle this plastic?
Well, one can only hope, right? Otherwise, if there's no hope, what are we going to do? But I think an interesting point, I'll make a corollary in the OR or even in dialysis. If you have gauzes that have blood on them, right now it goes into the biohazard trash. But if you think about it, women who are having their period and throw away like sanitary napkins, they throw them in the regular trash. So if something has blood on it, does it necessarily need to go into the biohazard? I think tubing may be different, but I think definitely gowns, gauzes, gloves, which creates part of the burden also, can be managed differently. And we know that because the company we were hoping to work with was willing to recycle not the gauzes, but like gowns and drapes that had some degree of soiling, as long as it wasn't like bloodbath kind of soiling. So I think that's one part, is changing policies on what needs to go where. The same way that when we learned recycling, does this go in the recycling? Does this go in the recycling at home? I think something similar will happen in medical institutions. For plastic, I think it's a complicated question, but I think as we are trying to move away from using oil and petroleum, I think production of plastic is going to be different too. I don't know if biodegradable is quite there yet, but definitely I think there's ways to think about this.
Thank you so much. It's 4 o'clock here in Montreal. So yeah, thanks again everyone for attending. We didn't expect that many people attending, so that's great for one of the PEDS, CST PEDS education session. Thanks, huge thanks to Rob Smith who was here during all the webinar, making sure no trouble happened during our Zoom meeting.